Yeah. Good morning, all. I will just run through what CB naught is. We all should know what is CB naught. We all should know what a PCR for tuberculosis is. We all should know what a gene expert is. The subtle differences between each of these. Sometimes in the exam, we talk everything about the gene expert. Then suddenly they ask you what exactly is gene expert. Then we are completely taken aback. No, that's sort of a thing should not happen. CB naught is a cartridge-based nucleic acid amplification test. CBNAAT stands for cartridge-based nucleic acid amplification test. What does that mean? That means you have a small bit of a DNA fragment available for you, and that can get magnified out of proportions. That will actually identify whether the bacillus, Mycobacterium tuberculosis bacillus, is present in that sample or not. What we normally do is urine for AFB and urine for PCR and urine for CB naught we do. So this sample of urine that we give for CB naught study, so that if it contains a small amount of DNA also, that can be. Otherwise, what will happen is if you do a routine urine for AFB, if that hyperfill does not show in organism, the microbiologist will have a tendency to report that is urine for AFB negative. Though they will actually screen 100 other hyperfills also, but still there is a possibility that smaller one or two AFB here and there may get missed out. Whereas CB naught will pick up all the smaller ones also, small fragment of a DNA also, that will get magnified and will get the report as positive. That means CB naught will tell you whether there is any fragment of DNA present or not. That's what I had mentioned here. It indicates that the Mycobacterium tuberculosis is present in the urine sample. And if it is positive, that confirms a GUTB. Please remember, I will talk a little more in detail about the South Indian consensus, which is more practically applicable for an Indian scenario. I will talk about that in greater detail in subsequent session today. And if there is a CB naught positive, the treating physician, the urologist, is licensed or given the authority to start the patient on ATT, and it is valid in the court of law. That is one advantage of CB naught. Number one. Number two, it will also tell you that CB naught report will tell you whether that particular mycobacteria is sensitive or resistant to rifampicin. Rifampicin is a drug which is very important in anti-tuberculosis therapy, as we all know. If an organism is sensitive to rifampicin, that means it will be sensitive to INH also, most of the times, more than 90 to 95% of the times. If an organism, if Mycobacterium tuberculosis is sensitive to rifampicin, it is sensitive to INH also. And if it is resistant to rifampicin, if that particular tuberculosis bacteria is resistant, if the CB naught shows resistance to rifampicin, there is no point in continuing with INH and rifampicin. That means that organism will also be resistant to INH most of the times, not always. It cannot be taken as a blanket statement, but most of the times, more than 90 to 95% of the times, if the TB naught shows sensitivity to rifampicin, then it is sensitive to INH also. If it shows resistance to rifampicin, that means it is resistant to INH also. So once you make a diagnosis of a CB naught positivity, there is no real further need for you to go for further testing with microbiology or radioimmunoassays or whatever it is. It is not really required. CB naught is one test, as I had mentioned the last time, that if you give the sample in the morning, you get the report in the evening. In 2 to 3 hours, they get the reporting done. Maybe in a day, you get the report. Okay, so tomorrow, the next day morning, when it comes, the report will be on your table, whether it is sensitive, whether it is positive or negative. Number one, number two, whether it is sensitive or resistant to rifampicin. This CB naught is so much important these days because if you can identify an organism which is resistant to rifampicin, there is no point in continuing INH and rifampicin for 4 drugs for 2 months and 2 drugs for 4 months. And then at the end of 6 months, you come to realize that this particular organism is not sensitive to these first line drugs. You also lose the vital time of window of curability, we call. No? The vital time is lost. Number one, the kidney also goes in for continued. If there is an obstruction that goes in for continued obstruction, and that will actually cause more harm to the kidney than good. And by the time you realize that the particular organism will not respond to the first line drugs, the kidney will become non-functional. So it's very important for you to do this particular CB naught in all the patients as much as you can. Wherever there is a facility available, you should do CB naught. Okay. And the other question that will commonly be asked is what is gene expert, what is CB naught? I had actually mentioned in the last class also for those who had missed it out, because there were a few PGs who personally messaged me and asked me what is gene expert, what is CB naught, what is the difference between the two. I think they had probably not followed it when I said, or maybe I had run through that a little faster. possible. But anyhow, doesn't matter. I will repeat that again today. Gene expert and CB naught are the one and the same. CB naught is actually a broad category of diagnostic test that detects the nucleic acids of a pathogen in the cartridge-based automated system, which is nothing but CB naught we call. On the other hand, Gene Expert, if you see, Gene Expert is actually a specific platform developed by one particular company that runs this CB naught machine. CB naught test. Okay, CB naught is the test, whereas Gene Expert is the platform. Like for example, you can also put it in a simpler way. You have a generic name and you have a brand name for that. Paracetamol is a generic name. Calpol or Crocin or Dolo 650 becomes a brand name. So this brand name is the Gene Expert, whereas paracetamol is the generic name. The generic name is the CB naught. CB naught is the basic test that we do, a cartridge-based PCR assay, whereas Gene Expert is the machine or the system or the brand that actually performs the CB naught. Hope it is very clear now. Okay, you can also run. Yeah, I will send you the um, I will send you the PDF also at the end of this session so that you can go through this again. For those who have not understood, we've got a lot of other topics to cover also. So I will stop here. Gene expert and CB naught, this is the basic difference. I've also simplified that and put that in a tabular a column so that you can, the same thing what I had mentioned earlier, I've repeated that here in the form of a tabular column. So what you should interpret is, if the CB naught is positive or negative, that means the test result is positive or negative for tuberculosis. That's all that you should remember. Whereas Gene Expert refers to the hardware and the software. That is the brand company that does that particular CB naught test. No, that is given the name as Gene Expert. So that is the only difference that you should understand between the two. On the other hand, there's another entity called the PCR for tuberculosis. We send the urine sample for PCR for tuberculosis. That also is the same as the CB naught. The only difference between CB naught and the polymerase chain reaction, that is the PCR test, is that the PCR will only tell you the presence of or absence of the DNA of Mycobacterium tuberculosis. That will only PCR will only tell you whether that MTB DNA is present or not. It will not tell you whether that particular organism is sensitive to or resistant to any of the anti-tuberculous. So that information you will not get with your PCR for tuberculosis. Whereas CB naught will tell you not only whether the organism is present or not, it will also tell you whether that particular Mycobacterium MTB bacteria is sensitive or resistant to rifampicin. The PCR, you get the report in 1 to 2 days. CB naught is much more rapid. You give the sample in the morning, you send the sample in the morning, you get the report in the evening. It takes only about 2 to 3 hours. Such a rapid testing CB naught is. So it's very reliable also. I think you can, you are legally protected if you plan your treatment based on your CB naught results or report. Okay. Again, I've given you a comparison. You can go through the same what I had discussed earlier. I've repeated that here again now. The WHO and this NTEP, please remember the term NTEP. NTEP is National Tuberculosis Eradication or Elimination Program. We initially called that before 1992. The government of India called this initiative to eradicate tuberculosis as National Tuberculosis Control Program. Following 1992, it became National Tuberculosis Control Program revised, that is RNTCP, Revised National Tuberculosis Control Program. Till 2005, they were talking about controlling the. 2005, they realized that what is the point in calling it control program, control program? We have been doing this for more than 2 decades now. So what we should do is we should actually start calling it an elimination program. We have to eliminate or eradicate this particular organism from the society, from the community, from the country. That is the initiative the government of India had taken, which they called as NTEP. The current program is actually NTEP. They initially thought it should be NTEP 2025, and then they made it 2030 now. Okay, 2030. NTEP 2030 is the current practice program as on date by the government of India. Okay, so this small understanding about the PCR for tuberculosis and the CB naught you should have in mind so that it will be easy for you to plan your treatment or your exam discussion recording. Okay, same I have repeated here. Somebody was asking me last time, why only for rifampicin resistance? You should look for, can't you look for INH resistance also? Sometimes one candidate had personally messaged me saying that You say when it is resistant to rifampicin, it may be sensitive, it may be resistant to INH also. If you specifically look for sensitivity or resistant to INH, then there is a possibility that there may be INH resistance, but there may be rifampicin sensitivity. So there is a test which can exclusively look for resistance to INH, which is a line probe assay. Line probe assay is it's another test, or the whole genome sequencing, WGS, which we call. These are the two tests which can actually look for specifically sensitivity or resistance to INH, specifically look for sensitivity or resistance to rifampicin. The line probe as a LPA and this whole genome sequencing. Please read a little more about it. I'm just giving you some overview about it. If anybody wants to know a little more detail about each of these assays, then you can go through that independently, individually. Okay. The gene expert or CB NAT, which we call, we talked about sensitivity or resistance to rifampicin. Nowadays, what happens is that there is an extended gene expert, which is called as extended CB NAT, which is called as gene expert MTB or XDR, multi-drug resistance. So we were talking about a gene expert or CB NAT. Now there's another development called the gene expert MTB XDR. XDR is extended, that is drug resistance. So it can also, earlier it was only, we were talking about sensitivity or resistance to rifampicin. Now we have got the facility to actually look for sensitivity and resistance to not only INH and rifampicin, but also to the second line drugs, fluoroquinones, cycloserine, and then clofazimine, and linezolid and all that. So we have more and more developments coming up nowadays. So we can also look for the first sitting itself whether the particular organism is sensitive or resistance to first line as well as the second line drugs. That is called as gene expert XDR. Okay, so that is the extended version of CB NAT. Okay. The rifampicin resistant tuberculosis, which is called as a multi-drug resistance tuberculosis. The principles that you'll have to remember is that, as I mentioned earlier, 90% of them will also be resistant to INH. And such patients should not be treated with first line drugs alone. Okay. And immediate, once you find that the patient is not responding to the first line drug, that means there is no point in treating those patients in your center. There are some centers, there are centers available where they treat multi-drug resistant. They put them on more intensive follow-up. That is called DOTS plus. I will come to that little later. And those centers will take care of treating such patients. If supposing you have a patient who is resistant to INH and rifampicin, better to refer the patient to that center, which will take care of the drug-resistant tuberculosis also. And wherever possible, if it is necessary, we can always get line probe assay done or the drug sensitivity testing done in those centers. We cannot do it on a routine basis in the regular centers here. Okay, fine. Next slide. So I talked about NTCP, I talked about RNTCP, then I talked about NTEP. The NTEP is a new National Tuberculosis Elimination Program where we have treatment for multi-drug resistant tuberculosis also. Okay, for multi-drug, I'll talk about this in greater detail again in the subsequent session on medical management of tuberculosis. We have a shorter MDR-TB regime for 9 to 11 months. We have a longer MDR treatment. I'll talk about which one needs what subsequent sections. Okay, next slide. So the basic difference between RNTCP and NTP is that RNTCP mainly focused on, we called it a category 1, 2, and 3 regime in RNTCP, and the category 4 was multi-drug regime. Now they have simplified everything, saying drug resistant and drug sensitive. Okay, drug sensitive is category 1, and there are only 2 regimens now. One is the organism sensitive to any of the first line drugs, the organism resistant to any of the first line drugs. Okay, so that is what you should do. NTEP, what does NTEP say? If supposing you have a patient who needs a particular drug, never add single drug to a failing regime. If you have a patient who is not responding to the drug, just don't add one more drug. Just add one levofloxacin. Don't add just amikacin. Don't add just one capreomycin or ethionamide. Don't add just one moxifloxacin. Add 4 or 5 drugs so that you hit the bug really hard with multiple antibiotics and anti-tuberculosis treatment so that the organism gets completely. Your aim should be to not just control, your aim should be to eliminate. That is what the NTEP program says now. So if the patient is resistant to if the organism is resistant, if CB not shows resistance, then immediately you should refer the patient to a center which will take care of the dots plus. The difference between dots and dots plus is that dots plus will take care of the MDR also. So you have to refer the patient to those select centers which will take care of the multi-drug resistant tuberculosis also. So they will treat the patient accordingly. Okay, next slide. The main second line drugs that you should remember are clofazimine. Clofazimine, we all know it's an anti-leprosy drug. It has now been included in the Mycobacterium second line drug for multi-drug resistant tuberculosis, also clofazimine. And then we all know bedaquiline. Bedaquiline can itself be short notes or a 10-mark question for you. And maybe in the discussion for ward rounds or the short case, if you get a case of GOTB, bedaquiline, linezolid will definitely be asked. We all know what linezolid is. Linezolid is a drug which has been used for MRSA, the methicillin resistant staph aureus. This drug has been extensively being used, and that drug also finds a place in treatment of multi-drug resistant tuberculosis. These are the three main drugs. Of course, we have kanamycin, we have amikacin, we have moxifloxacin, we have the other second line drug, cycloserine, and all those drugs are there, but anyhow, these are the three main drugs for multi-drug resistant tuberculosis that you should be aware of. You should know for each of the drugs the mechanism of action, the primary use, where it was being used, where it is used now, and the dosage, the half-life of it, the key adverse effects, what precautions you should take when you start the patient for any of these drugs, the advantages, limitations, everything you should know about these three drugs, because individually these are the three drugs which can be short notes for you, or treatment of multi-drug resistance can again be a 10-mark question for you, or each of the individual drugs may be asked separate. Next slide, please. Each of the individual drugs may be asked as a separate topic in your clinical case discussion also. The DNA PCR for tuberculosis, as I mentioned earlier, it identifies the DNA in Mycobacterium DNA, and usually that will Mycobacterium tuberculosis DNA, and usually that will target one particular sequence, that is IS6110. Actually, not required for you to know so much in detail. Sometimes when you answer everything about in long case and everything in short case and water, somewhere the examiner would like to know where exactly you fumble, so that they can stop the discussion. That is the time when all these things will be asked. These are the final details about the DNA PCR for tuberculosis, which if you can remember well and good, if you cannot remember also, no problem at all. These are the drugs, these are the points which will probably give you those extra points or brownie points we call, so that the examiner can be convinced to give you a medal for the in your bag. So these are the points that you should remember for that particular reason. All the other things we have mentioned, very useful in possibacillary tuberculosis, where sometimes the ESB is negative, the gene expert can pick up, this DNA PCR can pick up an organism. The only problem with that is this is the advantage. The main advantage is that even if the EN for AFB is negative, sometimes the gene expert or DNA PCR can pick it up. But the main problem with PCR is that they had mentioned that last time also. The main limitation of this particular test is that it cannot differentiate between a dead and a live bacilli. The DNA will be the dead bacilli and the live bacilli, both will have the DNA component. And if it is positive, that does not mean that there is an active ongoing infection. That is one thing which you should remember. It will only tell you that that particular sample contains MTB. That is all this DNA PCR will tell you. This does not tell you whether the urine is infected. Once you have a patient in whom this gene expert is positive, the next thing you should do is to correlate that particular test result with your clinical findings and with the radiological findings, and then see whether the patient needs the treatment or not. That is the way. Next slide. That is the way you should be able to. That is the way you should be able to apply this particular test in clinical practice. On the other hand, RNA PCR. The RNA PCR is much more informative, much more reliable than the DNA PCR, because this particular RNA PCR will tell you whether there is any viable and metabolically active bacillus present in that particular sample of urine or not. This RNA PCR, if it is positive, it means the that there is an active tuberculosis in that particular individual. Okay, so that is what it means. The problem with the RNA PCR is that it is not commercially available. It is there in next slide, please. It is there in only very few centers, You should know the basic differences which I have already listed out. Just for your easy understanding, I've just listed out the differences between the next slide, please. DNA PCR and the RNA PCR. You please read about the sequences that each one of these tests will identify. There are only a few centers which do that. Rajiv Gandhi Center for Biotechnology in Trivandrum, AAC in Bangalore, and another center in Bangalore, Rajiv Gandhi Institute of Chest Diseases, and this Gujarat Biotechnology. These are only few centers which do this RNA PCR mainly for research purpose, not for commercial intent, not with a commercial intent. That is why that is what you should understand. And that is why this RNA PCR is not being routinely used is because RNA is a very fragile one, and this degrades very quickly outside the living bacteria. So collecting the sample, storing it, transporting it, and then analyzing it and reporting it can be extremely challenging. So that is the reason why. On the other hand, DNA is much more stable. It will remain stable for a longer period of time, so that the reporting will be a lot more easier in with for DNA PCR than for the RNA PCR. Okay, next slide, please. That is the reason why this RNA PCR has not gained much popularity. So this is all about this PCR for tuberculosis. We talked in detail about the role of DNA PCR, what exactly is DNA PCR, what exactly is RNA PCR, what are the merits and demerits of each of them, what are the advantages and limitations of each of the DNA PCR, RNA PCR, and how this DNA PCR, gene export, and the CB0 can be helpful in initiating treatment either with the first line or with the second line directly, so that the vital period of window of curability, we call it, that window of curability period is not lost. That is the main important reason why the CB NAT has got a greater role to play. The CB NAT has got an excellent role to play because you can make a diagnosis of a drug-resistant tuberculosis with increasing HIV patients, with increasing immunocompromised individuals contracting tuberculosis these days. The probability of one having a multi-drug resistant tuberculosis in such individuals who are immunocompromised is very high. In such individuals, starting the patient on the first line and then realizing 2 months, 3 months, 4 months, 6 months later that the particular drug is not working in the particular individual, and then switching over to the second line drug, extremely foolishness on our part to lose that period of time, loss of manpower, loss of energy, loss of money, everything for that matter, and more side effects secondary to the and INS toxicity also will be there. Okay, hepatotoxicity is one of the main important, most important side effect or dose limiting side effect of these two drugs. So it's very important for you to make sure that the liver is well maintained and you use that particular drug wherever there is a real need. There is no real need if the particular rifampicin will not work on that individual. There is no point in treating them with first line drugs. You should switch over immediately to the second line agent. So that is the advantage of it is the main advantage, I should say, of this CB NAT. Okay, so CB NAT everybody should know in detail. PCR, RNA PCR, DNA PCR, the merits and demerits. Okay. Shall we move on to the next topic?